For the next session, I'm excited to introduce you to the next speaker and introduce you to the topic of the discussion, which is how to treat the patients with iron deficiency, either via IV or from PO, iron supplementation. Iron deficiency is a major issue in individuals with bleeding disorder. The studies has shown that in Canada, 10 to 20% of the women in childbearing age, they have iron deficiency, and the biggest risk factor is actually the excessive bleeding. So it's not surprising that iron deficiency and iron deficiency anemia are highly prevalent among women with inherited bleeding disorders. Iron repletion can be especially challenging for women and for those who are pregnant. A question that we always ask ourselves, and we try to answer it, is that what is the best way to deliver iron to an individual who is iron deficient? And there is a controversy regarding the best and most appropriate way to replace iron in the individual. On the background of this, I'm much honored to present you our lively and exciting part of our program, where about the debate on the IV iron versus oral iron repletion between two amazing hematologists who have been my mentors and role models for this part of the discussion. Geoff, you have an idea of the caliber and scale of this debate. I can inform you that our speakers are just flew back from Ottawa because they were attending Election Canada debates, just to have a better idea how to do debate. I know that because I was also there to see how to moderate a debate, and so this is how high the scale is. So you will. I'm sure that you will enjoy this meeting, and of course I was joking. So for the debate, I'm honored to present the two debaters, and on the right corner, and thank you organizers that they put Dr. Rochelle WINIKOFF on the right, because try to R Rochelle versus Michelle, it would have been pretty challenging and I would have messed it up. So on the right corner, we have Dr. Rochelle WINIKOFF, who's an assistant clinical professor in the Department of Pediatrics at the University of Montreal. She obtained her medical degree from McGill University in 1995 and continued her training in internal medicine and adult hematology. Since 2003, she's a staff hematologist at Sainte-Justine University Health Center in Montreal, Quebec, where she's the current clinical director of Women with Bleeding Disorders Multidisciplinary Program. She's currently the co-chair and past chair of the Association of Hemophilia Clinic Directors of Canada, Women with Bleeding Disorder Committee. She's honorary chair of the Canadian Hemophilia Society National CODEROUGE program and the recipient of the 2019 CHS Cecil Harris Award for her contribution to advancing the care of women with inherited bleeding disorders. On the left is Dr. Michelle SHOLZBERG. Michelle received her MDCM and residency training in internal medicine at McGill University, completed additional post-graduation training in hematology at University of Toronto, and a research hemostasis fellowship in Toronto and internationally. Dr. SHOLZBERG has a Master of Science from University of Toronto in clinical epidemiology and healthcare research, and was awarded the Claire Bombardier Award for Career Promise as a scientist. She is a clinician investigator with a focus on coagulation, the division head of hematology oncology at the medical director of coagulation laboratory at St. Michael's Hospital. She is also the director of hematology oncology clinic research group and co-director of the hematology immunology translational research team at the Lee Ka-shing Knowledge Institute. Currently, she is involved in the study of prediction tools for preoperative and traumatic bleeding, the intersection of women's health and bleeding disorders, treatment for iron deficiency anemia, new treatment for ITP, and the management of COVID-19 coagulopathy. Please enjoy the debate. Oh, I forgot to also comment that there are some rules to this debate that basically there's really no rules. But I think the presentation would be that the format would be that each of the presenters will present for 10 minutes, and then there would be a lively discussion for 5 minutes at the end. And at the end, we're going to have a vote from the audience of how each of the attendees were able to convey their message to you. Thank you.
Thank you very much, Dr. Ahmed. Okay, very good. Thank you. Okay, so I am going to tell you all of the reasons why oral iron is superior to intravenous iron. There are many reasons. This is the long list. I'm going to start first by reminding everyone that oral iron supplementation is a form of iron supplementation with the longest track record and history of efficacy. Okay. So the history of iron deficiency dates very, very far back to the earliest most available medical literature, and the treatments of this condition, originally called chlorosis, were available before people actually knew what they were treating. And so these ancient waters that were filled with iron were used to treat many different kinds of conditions and fatigue. And in fact, ferrous sulfate was invented before the cause of iron deficiency was found. And it's a pediatrician, Dr. McKay, who was the first to make the connection between iron deficiency and anemia in infants, and he successfully treated them with the oral iron salt. So really, history tells us a long story. And also, oral iron supplementation is the way to go because we are rigged to absorb iron well and to hold on to it. And we have been taught in medicine since the beginning of medical school that if the gut works, you should use it. And not only that, we are so efficient in our ability to absorb iron that we need so little to effectively make hemoglobin and myoglobin and all of the different enzymes and metabolic enzymes that we absorb just a small amount. It's all we need, 1 to 2 milligrams per day, even though our diet contains up to 20 milligrams. So it's just an amazingly efficient system. And we have such a sophisticated system to encourage the absorption, including vitamin C, something that is so natural and readily available all over the place. And look at this plate. This plate shows you the two forms of oral iron. So not only do we have oral iron to absorb, but there are also so many different types of oral iron. You can get it from meats. You can get it from grains and vegetables. And all you need to do is just drink a glass of orange juice and you absorb it even better. So really, oral replacement is natural. It exists in our natural environment as humans, and that's what we should be following. And so my colleague, Dr. WINIKOFF, might say, but what if the patient is bleeding too much? What do we do then? Is oral iron supplementation really the way to go? Well, my response to that is if the patient's bleeding too much, just stop it. And that's what we're trained for, right? We are members of the HCDC. All of our training has led us to the point of being able to effectively stop bleeding. So we just have to stop it. And I'd like to really call attention to the fact that iron deficiency is the real pandemic, not COVID-19. It affects a huge proportion of the world's population. And so how exactly are we going to treat the entire planet that is affected by iron deficiency with intravenous iron when it is so expensive? And so oral iron is inexpensive and thus can be made available universally to those in need. And so this is WHO data that shows that up to 33% of the population is iron deficient, and in some regions it's 65%. So how Dr. WINIKOFF is planning to administer intravenous iron to 65% of the population in some regions, I just don't know. I don't know where she's going to get the money. And really importantly, I need to call the attention to the fact that iron deficiency is a public health, equity, and social justice issue. There is a huge mismatch between who gets iron supplementation and who is tested and who actually needs it. So we are in need of products that are inexpensive, readily available, and well tolerated. And so just to give you an example, I'm going to compare now the similar cost of oral iron supplements, the iron salts, the most readily available around the world, to intravenous iron. So that's $9 compared to $550. It's so cheap. And even if I were to move to the more expensive oral iron supplements, it's still really cheap, $70 versus $550 for an equivalent amount of iron supplementation. And not only that, we now have studies that suggest that lower doses may even be as effective or more effective than higher doses. So you can even give it less frequently. So if you can give less, it's even better tolerated and it's even cheaper. And why do I feel so confident debating today on this topic? It's because I really feel that I am an expert in iron deficiency anemia. I have a research team dedicated to this, and I'm conducting a study right now with my colleague Yulia Lin that evaluates every other day oral iron supplementation for iron deficiency anemia. So I really know what I'm talking about. And again, Dr. WINIKOFF might say, but Michelle, intravenous iron can be covered by some governmental bodies. Well, that's true. However, that only accounts for people who meet the criteria for public coverage. And so it doesn't address the working poor. And that is a huge proportion of our population. And most importantly, there are really important undesirable adverse effects of intravenous iron. And one of these adverse effects relate to different amounts of labile iron content in different forms of intravenous iron. And this is associated with adverse cardiovascular outcomes and increased mortality. The risk of death is there. You will never hear me say that there is a risk of death with oral iron supplements. It just doesn't happen. And that extends even further. So patients can develop anaphylactic reactions. Again, risk of death. And not only that, it's really difficult to distinguish between the reactions that are very severe and put the patients at an increased risk of death compared to those that are mild and will respond to decreasing the rate of the infusion. So it's really challenging for clinicians to know what is a serious, life-threatening reaction versus one that is less serious. And this has gained so much attention that there is a Canadian expert consensus document that describes how anaphylactic reactions in response to intravenous iron should be done. So there's a group of Canadian experts that acknowledge the risk of anaphylaxis and the risk of death associated with intravenous iron. This is not, an insignificant problem. Now, yes, of course, there are some adverse effects associated with oral iron, but they're minor and they're mostly gastrointestinal. And I believe very strongly that with proper knowledge, translation, and exchange, that anything is possible. In fact, I've proven it. And first and foremost, this is with the Iron Mom, and I'm wearing the t-shirt today. That is a simple, digital, patient-centric KTE intervention that teaches pregnant women how to take oral iron. That's the intervention. We made an app, we made a website for practitioners, and notice that step one of the algorithm is start oral iron, not start intravenous iron. And we made pre-printed prescription pads. Notice intravenous iron's not on there. And did it work? We nailed it. It totally worked. In fact, we're going to be starting a large cluster randomized controlled trial to further address this. It works. But okay, you can say, but what about non-pregnant patients? What about those that we're really talking about today? Those with heavy menstrual bleeding? Well, again, with proper knowledge, translation, and exchange, you can address this. And here's our website called Take Control Period. And it teaches patients how to take tranexamic acid properly and how to take oral iron properly. Well, did it work? It did. We nailed it. We increased compliance of oral iron from 48% to 66% with a really simple website. Totally works. So, in summary, why is oral iron superior to intravenous iron? Number one, the longest track record in history. Number two, we're rigged to absorb iron, so if the gut works, use it. Number three, oral iron replacement is more natural. Number four, if the patient is bleeding too much, just stop it. We are trained hemostasis experts. Also, there are really scary adverse effects of intravenous iron, and oral iron is inexpensive, and so it can therefore be made universally available to those in need. And finally, with proper knowledge translation and exchange, anything is possible, and you can even overcome the pesky gastrointestinal side effects that sometimes occur with oral iron. Thank you.
So excellent. It was very educational and interesting. And now I'm inviting Dr. Rochelle WINIKOFF to present on the other side why IV may be better.
So there's a bit of an advantage of going second, and that's that I get to hear some of the untruths that I hear about oral iron. So I'm going to convince you in the next 10 minutes that IV iron is the way to go. It's that simple. I would like to also just say a little disclosure is that the attribution of the debate position today was on a coin toss. So actually heads was for IV iron, and I got attributed to defend IV iron. This was not our predisposed positions necessarily. I do receive honoraria from different advisory boards, and the one that might represent a conflict of interest today is that I am an ad board for anemia, perioperative anemia management with Pfizer, who make a monoferric or fer-isomaltoside. The important thing in a debate is to know your opponent. So Michelle comes across with many, many credentials, and she's a very impressive hematologist. But what you need to know about her is whether you could trust her or not. So first I want to say is that she says she's from Toronto, but she's actually from Montreal. The second thing is she has always, behind being a hematologist, been somewhat of an entrepreneur where she hangs out with the dragons, and she's been spotted here with them. And the most important thing, which makes her untrustworthy, is the fact that behind closed doors, she's actually secretly favors IV iron. And here's a tweet from her Twitter account where she sent out a petition actually saying the following: "This is a non-evidence-based statement referring to the event of maternal anaphylaxis. Please sign this petition to change the label to accurately reflect the safety of IV iron in pregnancy." I could probably stop the debate here, but I'll continue. There's no debate on whether iron deficiency and iron deficient anemia are a major problem in women, and it's most especially in women with bleeding disorders. It's common. It can prevent the need for red cell transfusion. It has a negative impact on quality of life of women affected. It can cause acquired platelet dysfunction, which can aggravate the bleeding disorders in these women. And it definitely has a negative impact on pregnancy and the fetus. But how best to treat it? The objective of my talk is to make this a slam dunk in favor of IV iron. Win this debate. What are the properties of an ideal drug? It needs to be effective, which is probably the most important thing, that it does what it says it's going to do, that it's safe, that it's selective, that it's predictable, that it's easy to administer, that it's free of drug interactions, and has a relatively low cost, or at least a comparatively low cost. Just as a reminder for the audience, IV iron is a simple construction or a construct where there's an oxyhydroxic core and a carbohydrate shell. And those two components are responsible for the different properties of each of the irons. This is just a table to remind us that there are many available, starting with oral dextran and iron sucrose and fer-isomaltoside, which is the new generation monoferric. And each of them have different properties, but of note, the newer generations can actually be administered in fewer sittings, if not a single sitting. So this is a major advantage for patients who are iron deficient. It's effective and fast. So this is a meta-analysis, a systematic review that included 18 randomized controlled trials, if not more, to over 20, with a total of 2,000 patients that were pregnant in the antepartum and postpartum periods. And what you can see here is that there is a clear advantage of iron deficiency, of treating iron deficiency with IV iron, and its impact on the hemoglobin at every step of the way, week 2, 3, and 4 after treatment, is in clear advantage of giving IV iron, as you can see from the plot graph, where to the left is in favor of iron sucrose, which is an IV, and to the right, which is almost white on the slide, is in favor of oral, which there are almost none. IV iron is also faster. So I'm going to take you to the right of the slide first and to show you an observational study where they compared oral versus intravenous iron therapy in iron deficiency. And what you can see is as of day 14, there's a significantly increase in hemoglobin in the IV group that's statistically significant and clinically significantly higher than in the oral group. And that's true as well at day 28. The same is true for increases in ferritin when using IV iron compared to oral. And on the left, the question that was asked here is, if you use IV iron late in pregnancy, where red cell expansion becomes very important, is it still effective? And the answer is yes. As of day 14, what you could see is that there's an increase in hemoglobin that's significant as of day 14, all the way to time to delivery. This graph, what it's showing is the fact that if you look at the bar graph to the right of the first graph, what it's showing you is that in red are the recipients of IV iron. And what it's showing you is that the vast majority of patients included in this study, of which there were 100, had increases in hemoglobin of greater than 20 grams versus a minority of patients that had the same increment in hemoglobin receiving oral iron. And what's more important in the bottom graph is if I take your attention to the second vertical bars, you see that serum ferritins of 50 to 100 are only achieved in IV iron patients receiving IV iron and not oral. And Michelle is a very big advocate for having ferritin stores that are adequate before delivery. Well, the only way, according to the study, to achieve that is using IV iron. It's also safe. So if we look at anaphylaxis with IV iron, what I say is it a real worry or PTSD from old formulations of iron dextran, where we used to see anaphylaxis quite frequently. If you look at the current numbers using, for example, iron sucrose, you can see that the reported incidence of anaphylaxis and true anaphylaxis is 0.6 in a million. This is a very rare side effect, and to be distinguished from infusion reactions, which can lead to which can cause reactions, but not of the anaphylactic and nature that are mortal. The newer formulations even report lower levels of anaphylaxis than the older versions. Here's a systematic review and a meta-analysis looking at the safety of intravenous iron preparations that includes 103 trials, a total of 10,000 patients that received IV versus 4,000 that received oral. And what you can see is, by this relative risk of 1.04, is that there was no increased risk of severe adverse events in patients receiving IV iron. It also has very few side effects. So I know we heard from Michelle saying there's these little bothersome side effects. But what I could show you here is that if you use intravenous iron sucrose, so to the right of the graph, you could see that there are no GI side effects with iron treatment. Anaphylaxis in this particular study was 0 in 100 patients. Hypotension was transient in 1 patient, and some patients do get arthralgias and fever that are related to the transfusion, but are usually go back into their self treated. So they don't require much intervention and they're very temporary. So in total, what you could see is that the number of side effects that are reported with oral iron regimens, and all of them in the literature, have at least double, if not triple, the amount of reported side effects from women receiving them. of course, when you have that many side effects, adherence to oral iron is difficult. So this is a study that I love, with looking at 300 patients from a gynae obstetric practice in a pediatric hospital, and looked at the number of patients that are actually compliant with the regimens that Dr. SHOLZBERG is prescribing. And what you can see is that only 16 are highly compliant, and more than a half have low compliance, and most of the reasons reported are side effects. And the other big reason is forgetting to take the pills altogether. So this is not very efficient. The effect of IV iron is extremely predictable. And why? Because you're giving it directly in the vein, and it's not affected by GI problems, gut absorption issues, and it's certainly not affected by the whole hepcidin body iron regulation mechanism that is in charge of increasing iron from the gut. In addition to that, not only is the IV much more direct and reliable in terms of its effect, we know that the oral iron pills is very poorly absorbed, which only 2 to 3 milligrams per 100 milligrams of consumed iron absorbed. So that's why you have to take it so often, so much, and for so long. It's also really easy to administer. It's given by a simple IV access. It can be given anywhere in a local clinic, in Quebec in a CSC, by a home nurse even. It requires sometimes just a single dose or even a few doses. There's no prolonged oral treatments and complicated treatment and prescription regimens. And what's really important is that you don't need all that repeated clinical follow-up to ensure adequate response and review side effects with the patient and flip-flopping from regimen to regimen with different oral pills. If this doesn't give you a headache, I don't know what will. But these are all the things that you need to consider when you're prescribing oral iron to a patient. It's decreased absorption with a lot of foods, especially caffeine and calcium, and it's decreased also by certain pills like antacids and some antibiotics. It's also free from drug interactions. I don't know of any drug interactions with IV iron. And lastly, in a study that was published in Seminars of Hematology, it has an overall cost utility that appears to be similar to oral iron. So in summary, WINIKOFF versus SHOLZBERG. I'm going to take you through our offices on a day. WINIKOFF, I have the right solution for you. SHOLZBERG, now just hear me out, she says to the patient. So the script at first, WINIKOFF, monoferric IV times 1 dose over 15 minutes. SHOLZBERG, I'm going to prescribe to you ferrous sulfate, 300 milligrams 3 times daily. But when you take a closer look, Michelle SHOLZBERG also adds 3 months to the prescription. She gives you a laxative called Laxaday because she knows that it's going to cause constipation. And she asks you to take it with some vitamin C so that it increases absorption because she knows that it's not absorbed very well. If you go even closer in the fine print, what you're going to see WINIKOFF saying is, you'll be done in 20 minutes or so and you'll feel better soon. Let's just go ahead and book your appointment this week. What you'll see in the fine print of SHOLZBERG is, I've prescribed you an oral laxative because it can be super constipating, the oral iron. You might want to take it twice daily or every other second day, since 3 times daily might not be very well absorbed, and the literature is a bit confusing on that. You may have some nausea and heartburn and maybe some flatulence and some constipation. And I actually know that your pregnancy is already really hard on you as it is, with all those similar symptoms and the vomiting. And this may add to that, but I'm really hoping it doesn't, because only 30% of patients experience that. And also, when you're taking your pill, try to take it on an empty stomach and avoid eating dairy products when you take your iron pills, as it may decrease the absorption. And don't take it close to your Zantac that you take for your heartburn for the same reason. Taking it with some orange juice may help increase the absorption, or you can take it with the vitamin C that I prescribed. And don't feel scared because your stool may turn black. This is not a cause of concern. It's just the oral iron that does that. And finally, don't skip doses, since they might not work at all if you don't take all your doses. I know it's hard to remember to take pills every day, and you may not want to if it makes you feel sick, but do your best. If it doesn't work, there are other pills to try. And finally, don't be discouraged. And finally, don't expect to feel any better for at least a few weeks to a month, as oral iron works slowly, but we should be okay by the time of your delivery. Finally, be careful what you wish for.
Okay, that was very exciting and educational. And now we're going to go to the next part of the debate, and when I'm going to invite both the debatees to have a direct and exciting and lively discussion.
Thank you very much. So Dr. WINIKOFF is absolutely right that it was a coin toss in terms of who received oral iron versus who received intravenous iron. However, Dr. WINIKOFF is the chair of the program today, and I'm not certain if there was a coin toss as to who was to go first versus second. So she mentioned that it was an advantage to hear my presentation first. Well, she's right, and she may have rigged it all. Second of all, she's really convincing, isn't she? She's presented so many arguments, right? Comparing numerous studies, presenting systematic reviews and meta-analyses of the data, comparing oral iron to intravenous iron. However, I never pretended that oral iron on its own was enough. I said that oral iron with proper knowledge translation and exchange interventions is enough. And that's what I've developed in my research program. And so I completely agree that giving a patient a pill and sending them off on their way is not the right way to do things. Instead, we have to commit to improving our overall healthcare system and the tools that we provide to our patients, and to really engage with our patients as partners. In her last slide, where she presents how she counsels patients prior to their receipt of intravenous iron versus mine when I'm counseling patients for oral iron, I feel as if anything, she simply just showed that I'm a lot more comprehensive in my discussions with patients. All she said was, you'll get an IV, it'll infuse for 20 minutes, and you'll feel better soon. No discussion of adverse effects, including the one that's associated with the risk of death. Like, that's pretty crazy and medical legally problematic. Second of all, I would never prescribe oral iron supplementation 3 times per day, nor have I ever suggested that I would. And so, again, this comes back to the KTE interventions that myself and my research team have developed and proven that they work. Now, she did mention initially her financial conflict of interest, and this is really important. And I'd like to emphasize why I didn't mention any financial conflicts of interest related to oral iron for myself, and that's because I have none. So that's a really important thing to remember. Also, when she mentioned my Twitter feed where I encouraged people to sign a petition against erroneous drug labeling, that actually, if anything, just shows that I'm a really committed doctor and that I'm against any inaccurate drug labeling. And I would do that for any medication, even if it were true for oral iron supplementation. So finally, I'd like to end on the note of me pretending that I'm from Toronto. I never pretended that I was from Toronto. I'm born and bred in Montreal, and I moved to Toronto for my residency, and I was subsequently recruited to the largest hemophilia treatment center in Canada, which is why I stayed. So that's my rebuttal for right now, and thank you for the opportunity.
Is it my turn to rebuttal now? Because if it is, I need my slide. So I have something to read.
Yeah, thank you, Michelle. Dr. Rochelle, I think we are waiting for your slides to be uploaded for your rebuttal.
Yeah. So maybe while we're waiting for this slide, I can ask Michelle a question to make this livelier than that. But when you were involved in circulating that petition of yours, were you not the lead author on it? Your name is first on the petition.
Yeah, so that was a petition that was developed by a wonderful resident who works with me, Dr. Sophia Wen, and a team of other hematologists and experts. But yes, I was the supervisor for that. But it's not a study, and it's not necessarily even something that we intend to publish. It just relates to our CanMed role of advocacy.
Mm-hmm. I'm going to read it. Okay, I highlighted a paragraph in there that I thought was really important for today. So here it goes. So it's almost like a thesis, okay? It's been researched, there are references which I think are credible. So oral iron supplementation in pregnancy has been shown to improve anemia and reduce the need for red cell transfusions. I'm going to agree with that. However, oral iron is poorly absorbed, as we've shown. This necessitates several months of daily supplementation to adequately replenish iron stores. Additionally, oral iron is often poorly tolerated. Many patients experience gastrointestinal side effects that lead to treatment non-adherence. As pregnant patients already experience constipation, and they may add nausea, heartburn, and a whole bunch of others, this makes taking oral iron even more challenging. As anemia becomes more prevalent and severe later in pregnancy, IV iron is frequently used to safely and rapidly increase iron stores and to correct the anemia as delivery approaches. Compared to oral iron, and I'm going to repeat that, compared to oral iron, IV iron has not been shown to have increased rates of severe adverse events and has been shown to be better tolerated. It has been shown to be better tolerated with fewer gastrointestinal side effects with enhanced treatment adherence. In our experience, the risk of fetal bradycardia or fetal demise pertains to the theoretical risk of fetal harm in the event of maternal anaphylaxis. We believe, therefore, that this labeling is misleading for both clinicians and patients alike. SHOLZBERG. I rest my case.
Thank you, Dr. WINIKOFF. Although I would like to call your attention that this petition was drafted specifically with a focus on the use of these iron supplements in pregnant patients and does not necessarily address the patient population that we were asked to debate today, meaning iron deficiency anemia amongst women with bleeding disorders. And as you know, essentially all of our patients develop iron deficiency anemia from heavy menstrual bleeding. And so this paper that you're presenting, or this petition that you are presenting, specifically relates to pregnant patients. And so the focus of the debate today, though, is on patients with bleeding disorders, where heavy menstrual bleeding is the predominant cause of the iron deficiency. So I think it's really important for us to focus on what we were asked to debate. So I'm not going to take your bait.
So amazing. At the end of this, I have a feeling that when I become iron deficient, I'm going to get an IV iron with the side of oral iron together. So it's like it was such a convincing debate from both sides. So I think we are going to go to our voting part. In a sense, to see who had put a better argument of IV versus PO. Yeah, in the live feed there is a live quiz that you can select oral iron versus intravenous iron.
Well, I just want to say that was a total pleasure and hilarious.
We're in studio, by the way. We're actually in a studio. And Michelle, she didn't show up. She didn't even show up. She stayed in a t-shirt at home. Well, we had makeup and hair and everything, clearly.
Oh yeah. Well, but that's because I'm working. I mean, I'm working. It's still, a really serious pandemic here in Toronto. I can't just get on a plane and get into a fancy studio.
No, and prescribe your oral iron on the go, eh?
Are you administering intravenous iron right now to the members of the studio audience?
No, because Karen and I are alone in this. Because Karen and I are alone in the studio, so we have no access to do anything. I'm with Karen Fahey over here. She's. We have a plexiglass between us. There she is. Is the audience asking questions? Because I think that they were allowed to weigh in terms of opinions and things like that, Ali.
Oh, you're muted.
Yes. So I think we have the results available, So drum roll, please. So the oral iron versus IV iron, there were 71% vote for IV iron, 29% vote for oral iron.
It was rigged. It was rigged.
Nah, I don't think so. I think the evidence speaks for itself. Truce.
So
she's my good colleague. You know, it's hard to do this against a good colleague. We have so much respect for her, but I can't say it wasn't fun.
Of course, it was great. And of course, I'm a big proponent of intravenous iron and oral iron when it's appropriate, of course.
And I'm not as much, as you know. So I'm an oral iron advocate, so which made this even funnier. But I think my philosophy and take on the literature is making me change.
So it was amazing, and we really enjoyed it and learned, but more enjoyed. But definitely a lot of learning. So it was. Thank you so much for educating us. And it was really pleasure to hear the both sides of the arguments. So I think I didn't see any particular question. But there are a lot of compliments that I see being posted, which is shared all over. So thank you so much for the both presenters, and thanks for the organizing committee and everyone.
Thank you very much.
Bye.